Hi, everyone. Thanks for being here. I'm excited that they've organized us in this order because I think this is going to fill in the gap about the Spanish-speaking individuals, but it also plays off of Rebecca's work. So I think it's kind of like they planned this or something. Again, my name is Sara. I have no disclosures to report. And first of all, I need to thank the research team, Doctors Natalie Tedford, Brenda Luther, Jiawen Guo, Lisa Diamond, and our fearless leader, Andrea Wallace, who's somewhere here. And also, this work was funded by the National Institute of Nursing Research and the American Academy of Pediatrics Access to Child Health Implementation Grant. So I'm going to provide just a tiny bit of brief background on our team's prior findings, basically to just illustrate the impetus for the current study. So our team has extensive experience screening for social needs. Across several studies, we've consistently found what we refer to as a voltage drop. And it's pictured here in this figure. And it's from initial screening to the acceptance of contact to the receipt of resource referrals. Ultimately, about 79% of individuals who requested assistance to meet unmet needs did not receive referrals. And these voltage drops were assessed early on in a study that we were conducting assessing screening in the emergency department. We basically wanted to see what we could learn about barriers and what would improve the uptake of screening and referrals. For additional information, feel free to take a look at these two studies, which are also on the references slide and available in your app. So given this voltage drop seen between the stages of screening and referral processes, we wanted to explore the barriers and the facilitators to participation and engagement in social needs screening and referral processes experienced by patients in medical settings. In this study, we used two theoretical frameworks to inform our analysis: general unsafety theory of stress, or GUTS theory, which if you think of it is kind of a perfect name for something, but you have a gut feeling of unsafety, right? And GUTS theory posits that chronic threat vigilance is the baseline state for the human nervous system because humans evolved in these dangerous and uncertain situations, and therefore it was adaptive to maintain this default state of awareness. According to GUTS theory, automatic threat vigilance is only disengaged by unmistakable safety cues. The second theory that informed our research was Slavich's social safety theory. And this theory really expanded these insights of GUTS by showing that the most important safety cues are social. So Slavich talks about how humans are social beings and we're deeply dependent on a group for survival. Therefore, we need social inclusion and protection to feel safe and secure. So the most powerful off switch for threat vigilance is really encountering this warm, affirmative, and protective human being. So from these two theories, we have two major insights about social screening. First, patients in healthcare settings are likely to occupy this threat vigilant state, given that these settings provoke feelings of vulnerability, being sick, not knowing what to expect, and also uncertainty. Thus, patients may have negative and threatening expectations of screening even before knowing the social care screening questions or how the process might even help them. Essentially, they already experience heightened defensiveness when the healthcare screener approaches them, and this leads us to expect that maybe the most common reason for people declining the screening process or declining outreach for community resources are not lack of time or disinterest, but are really these threats such as fear of rejection, fear of abandonment, and fear of judgment. And I know we talked about stigma earlier. The second major insight is really that these interpersonal cues of safety from the person conducting the screening really need to be present. And these are things like warmth and empathy and responsiveness. And these play a primary role in disengaging that state of threat vigilance. So GUTS and social safety theory indicate that humans don't need clear evidence to feel threatened. Rather, social fear is part of the brain's default response. When patients receive a warm, affirming, authentic, and respectful interaction with the screener, it should cue the nervous system to kind of call off the guard dogs, making patients more likely to engage. So we use these two frameworks to directly inform our efforts to look at the facilitators and barriers to social needs screening and referral processes. Just real briefly, our study was conducted between December 2022 and March 2023. We conducted 4 focus groups with 32 community dwelling adults. So we had 10 English speakers and 22 Spanish speakers. Focus groups were conducted by the Community Collaboration and Engagement Team of the Clinical and Translational Science Institute, and they really centered why participants would or would not answer the questions in the screening form. So the Sincere Screener is a psychometrically validated questionnaire. It contains 10 questions. It's low health literacy, available in English and Spanish, and takes about 3 to 5 minutes to complete. I don't expect you to read all of this text here. I just wanted to show you an example of what this might look like if you were handed an iPad and you were asked to complete this via REDCap. So the 10 domains that this covers are transportation to medical appointments, the cost of seeing a medical provider, paying for medication, having enough money for food, having enough money for clothing or furniture, paying your rent or mortgage, unstable housing, unemployment, and child or elder care. So our study was approved by the University of Utah IRB, and before the focus group, participants received electronic copies, not only of the consent form, but they also received the screening instrument ahead of time and the focus group questions that they would be asked. The questions, which are listed here, and again, I'm not going to go through these, but I wanted you to have them in case you were interested. They really, again, focused on not only each individual question and why people may or may not prefer to answer those questions, but also on the introduction explanation offered when people are approached. Focus groups were conducted virtually using Zoom and began with the introduction of the research team and the reasons for why we were doing this study in the first place. Groups lasted on average about 98 minutes. They were video recorded. They were transcribed verbatim by professional transcription services. The ones that were conducted in Spanish were translated into English and uploaded into in vivo qualitative analysis software. Again, if we had all the time in the world, I would go line by line and explain this whole analytic plan. Essentially, we use thematic coding and directed content analysis. And this process of unitization, which basically allows for higher inter-rater reliability, because the second coder isn't determining the length of the code itself. The length of the code is already, it's left highlighted, and then the second coder just has to apply the coding scheme to that highlighted code. So using a combination of deductive concepts, which were derived not only from social safety theory and also from GUTS, we looked through all those focus group transcripts. We also added some inductive concepts from the focus group transcripts, such as reassurance, sincerity, breach of confidentiality, shame, guilt, embarrassment, and lack of information. We reviewed the code book. We made sure there was consensus. We went through a couple iterations of this. Ultimately, we used in vivo to calculate intercoder reliability, which was at 0.66, suggesting good agreement between coders. So our demographic characteristics, as I said, we had 32 community dwelling adults. Participants were 35 years on average, and most were female and identified their ethnicity as Hispanic or Latino. Participants mostly lived in urban areas, and of the sample, 21 or 65.6% reported no prior contact with an information specialist. When you looked at the frequency of social safety codes versus the codes that we identified as social threats, we found 49 mentions of social safety versus 331 mentions of social threat. So social threats were really brought up 7 times more frequently than social safety. The other really interesting thing was that for social threats, they were all expectations of threats. And for social safety, they were all about persons' lived experiences. So the coding hierarchy, again, 2 major categories of codes. So for social safety, the codes within that ended up to be predictability, helpfulness, inclusivity, reassurance, sincerity, authenticity, and validation. And for social threats, those were aggression, breach of confidentiality, devaluation or condescension, discrimination, exclusion, insincerity, rejection, shame, guilt, embarrassment, which I kind of lumped together for reasons you'll see, and lack of information, misinformation, or vulnerability. Here are the coding frequencies. So the subcodes within social safety that were most frequently reported were helpfulness, and that had 16 occurrences, and that was about 4.2% of all codes. The next most frequent ones for social safety were inclusivity and predictability. Now, vulnerability at 86 instances, or 22.6% of the entire codes applied, was the social threat subcode most frequently reported, and the following 2 were exclusion at 15.3% of the data and aggression at 11.3% of the data. So I'm going to talk very briefly about the three most frequently reported social threats and social needs. There are a bunch of definitions and hopefully getting published soon, so be on the lookout for a paper that will have some more information. But helpfulness really involved participants feeling as if the individual doing the screening, offering the resource, or within a community service organization really operated in a way that would relieve burden and help meet their needs. So, for example, one participant stated that the information specialist connected me to what I was looking for, so I thought it was awesome. And another participant talked about how when they initially, another participant mentioned they found me a free program so I could get a tutor. When we're talking about inclusivity, participants felt like the community resource or the person conducting the screening was culturally welcoming, and that the resource or the organization or the help offered was really meant for people like them, people in their situation, people they could relate to. So this quote is, "It was finally available in whatever city they lived in." So that seemed really great to me. When we're talking about predictability, this was really in individuals following up with the participant. So feeling like they could count on the person conducting the social needs screening, feeling like what they asked for was followed through with. And the quote for this one is, "They called me, and that was really comforting for me, and it was easier to connect and have them follow through by calling you instead of giving you a piece of paper with the information." And this quote was from somebody actually who had completed a postpartum screening depression at their pediatrician's office. So the fact that they actually followed up with her while the patient was a child was really important, and I think connected her to some really critical resources in a time of need. For social threats, vulnerability involved feeling afraid, defensive, or susceptible. And a quote for this one is, "It's just a very hard situation to put yourself in and to ask for help." People also felt that some of the questions were really invasive, which I know we've referred to earlier here in this talk. I'm not saying this question is bad, but it's more invasive, it's more private. I don't have to answer it if I don't want to. I came here to get treated, is what this person was saying. For exclusion, one example is this quotation here. A lot of undocumented people can say, well, these services are provided, but are they provided for me? And then aggression. Families don't answer questions because they're worried it will lead to repercussions of child protective services. We had that response a lot. Also, some people may worry that answering this could affect their living situation. As you can imagine, we also had a lot of people talking about immigration, which I fear will be a constant thing in the years to come. So in conclusion, these results really do align with the notion that human brains maintain this default state of threat vigilance until safety cues are really detected. So accordingly, the only way to increase rates of screening is to head off this automatic threat vigilance with clear and concrete evidence of social safety before people are even given a screening instrument. These findings can assist healthcare organizations in developing safety-first protocols. And since I am running out of time, I'm just going to go through these real quickly. So we have, for each social threat, some suggestions for how healthcare organizations or people developing the screening tool could address these. So for aggression, you're going to assure that we won't make any contact with authorities and also ask permission for screening. We heard a lot. Don't just ask me the questions. Ask me if it's an okay time. Ask me if that's okay for you to ask these questions to me. Breach of confidentiality. This information will not be shared. Devaluation or condescension, speaking to the person at the same level, assuring them your time is valuable. Is this an okay time for you? And also stating that all patients are being screened, asking this in a non-judgmental manner. Stating that services are for all, regardless of legal status. Also remaining curious about other needs they might have. Maybe it's something that we didn't ask on the screener, but they really need to tell us something that is lacking. Building rapport. Talking about other resources that might be provided. So one of the things we also heard a lot was, well, I'm not going to apply for any help because the last time I applied, I went through 8,000 pages and I had to get someone's fax, and then the website crashed, and I finally got a hold of them and they said I didn't qualify because my income was too high. So talking to them about the fact that we understand a lot of these programs have really stringent eligibility criteria, and if you don't qualify, we will try to provide you with another resource. So this research underscores the importance of heading off social threat prior to screening for social needs. I've already talked about these implications, but by anticipating the potential for participants to experience social threats, we really can establish safety and improve patients' engagement in screening and referral processes, which ultimately, as you all know, is really tied to population health. So by doing this, I'm hoping that we can improve population health in the future. With that, I also recognize that I wrote these slides before January 21st, but I do really think it underscores the importance of this information. I think now more than ever, we're really going to need to understand how to handle situations where people perceive social threat constantly, are constantly vigilant, and are constantly threatened just by their mere existence. So I hope that this provides a little bit of help in how we might kind of forge a new way in the future and improve patient screening and uptake. Thank you.